Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! On today's episode, we explore the groundwork for a currently ongoing multi-center retrospective study in the aortic dissection space. This study is aimed at validating a clinical and imaging-based risk prediction model for late adverse events in patients with uncomplicated type B aortic dissections. The study, known as ROADMAP, brings together 10 academic aortic centers in North America and Europe to validate this risk prediction model. By analyzing clinical and imaging data from patients with initially uncomplicated type B dissections, the researchers seek to determine the model's effectiveness in predicting the risk of late adverse events, including aneurysm formation, aortic rupture, and organ malperfusion. In this conversation, I am joined by the lead and senior authors of the paper, Dr. Domenico Mastrodicasa and Dr. Dominik Fleischman. Let's jump into that conversation now. All right, listeners, I have with me the lead and senior authors of our featured paper, Dr. Domenico Mastrodicasa and Dr. Dominik Fleischman. Domenico and Dominik, why don't you tell us a little bit about yourselves? Where are you currently practicing, and what are your academic areas of interest? Domenico, why don't we begin with you?
Sure. Thank you for having us. And I'm the lead clinical scientist of the Stanford Cardiovascular Imaging Group here at Stanford. I've been here since 2018 as a postdoc. And my area of research is basically cardiovascular imaging, specifically aortic dissection.
Fantastic. And Dominik, how about yourself?
Yeah, I'm the chief of cardiovascular imaging at Stanford, and my research and clinical interests are obviously cardiovascular imaging, and I always had an interest in aortic diseases, to some extent triggered by the close collaboration with the surgeons at Stanford, and the Stanford classification, the Stanford surgeons. It had an impact on my career over the last 20 years.
Absolutely. And the concept of aortic disease ties in very closely with the publication that we're going to focus on in today's discussion. That publication specifically talks about adverse outcomes related to uncomplicated type B, Stanford type B aortic dissections. In this discussion, in the paper itself, you mentioned that thoracic endovascular repair of these aortic dissections is the most common intervention at present. However, the data to support TEVAR for such dissections is not all that robust. Was wondering if y'all could elaborate a little more on that to give some background for our listeners as to why we think the data is not all that robust for this particular intervention.
Yeah, let me walk you through that. The main issue with patients who have what we usually call an uncomplicated type B dissection is that, and here we're talking about patients who have a type B dissection during an hospitalization where they do not need a surgery or any treatment. That's why they're usually called uncomplicated. But the problem with this particular population is that we don't really know how to best treat them for their future events. About 40 to 60% of these patients do have late adverse events. So at some time down the road, they usually have some late complications. And the question is, can we prevent it? And there are some data that support this. There have been some trials shown that if you put in a thoracic endovascular aortic repair or TEVAR, that the false lumen thrombosis and the false lumen doesn't grow as much. So you would think that that's a good treatment to prevent that late complications. But the flip side is that some patients do very well without any intervention for many, many years, and TEVAR is not totally without complications. So the rate of complications for TEVAR is relatively low, but those are severe complications. So you can have a retrograde type A dissection, you can have a stroke, or even paraplegia. So the question is really, how do you manage those patients and who would benefit from endovascular repair and who didn't. Because despite there's all these controversies about, well, should we do preventive endografting, yes or no, and there are very strong opinions either direction, there's one thing where everybody really agrees, and that is, well, we need better risk stratification. If we knew who are the patients who develop complications, then this would help everybody, because then we would only treat those patients who would benefit from it and we would prevent the event from happening. Whereas the other patients, we should just do whatever we are already doing now, which is we treat them with antihypertensives, and they have both clinical and imaging surveillance, and we watch them and we see if the false lumen grows, and only if it grows we would intervene.
So, to my knowledge, both at my own institution as well as those at several within the United States, we use aortic size, aortic caliber to determine whether or not there may or may not be a downstream adverse event. Is there any merit in utilizing aortic size to determine downstream adverse prognosis?
Yeah, certainly there is. So the when you try to predict who will have a late complication, then there are some clinical predictors, but then there are these morphologic predictors, and aortic size and aortic diameter is still the best and most well known and most robust predictor of late adverse events. So if your aorta is already, I don't know, 4.5 or almost 5 centimeter just after the dissection, the chance that you need an intervention within the next 5 years is very, very high. But there are patients whose aorta is only, I don't know, 35 millimeters and the dissection is not very extensive, and those patients may never need an intervention. But so diameter is a very good and very strong predictor, but it's not the only one.
Excellent. I think that's great background to now go into the registry that you describe within the publication itself, the roadmap registry. From what I understand, this is a registry that is an international study based out of 10 different centers in multiple continents. It's an observational study, and the intent is to identify both clinical as well as imaging predictors for adverse events following uncomplicated type B aortic dissections. Domenico, can you go into a little more detail about the roadmap registry and study design?
Sure. Is actually, we thought about this, and I think that Dominic is actually the best person to tell you, because he's the one that actually saw the whole project going, and I'd like our audience to have him basically explain the whole idea.
Absolutely.
Yeah, so let me just give you one more piece of information before we go to the details of the study design, which was really where Mimo's work comes in, and where he really built some of the systematic pieces that needed to do this. Now, in terms of background, now if you want to look for morphologic predictors, then imaging obviously is a technique that you want to really study very, very hard. And there have been several studies that looked into other morphologic predictors. As you said, there's maximum diameter, but people also looked at the diameter of the false lumen. People looked at the false lumen thrombosis. And there's plenty of research articles that looked at one or two parameters, or there are even good research or review articles now that kind of give an overview of all the different things that have been explored to predict who may have a late complications or not. It also depends on communications between true and false lumen, etc., etc. Now, what we did several years ago is we thought that we should do a combination of these parameters. And a few years ago, and that was published back in 2017, we combined morphologic predictors that we were hoping, or we were inspired to use some physiologic background. So our basic idea was to say, well, the main problem with the false lumen aneurysm growth is that it's pressurized, and the larger it is, you have more area where you have these forces acting upon, which will lead to growth and ultimately lead to rupture. And So it makes sense that geometry plays a role, like diameter, or then the extent of how much of the circumference of the aorta is in fact false lumen on the outer wall. But also some flow parameters you could think of, and there's physiologic data that support that, that the blood that flows into the false lumen, if that is a lot and there's little blood that flows out, in other words, the outflow resistance is high, that also would be bad and would increase the false lumen pressure. So in order to capture this in a, I would say, almost a childish way, but we thought that's what we could do. We thought, well, we look at which of the branch vessels come off the true lumen and come off the false lumen. And we thought that the more come off the false lumen, the better it would decrease the pressure at the false lumen. So this should have a beneficial effect. So in that work, we showed that a combination of four morphologic parameters and one clinical parameter, the clinical parameter being connective tissue disease, the morphologic parameter being the size of the aorta, as you mentioned, but also the extent of the circumference, like how much of your total circumference is in fact false lumen, then the draining of the branch vessels, and also the number of intercostal arteries. And this was one predictive model that turned out to identify who are patients who develop late complications. Now, this is of course very exciting. We were all very happy about it. But then when we talk to the surgeon and say, look, here's a good model, we could use it, and we say, well, wait a minute. You only tested this in a very small cohort. So we only had like 80 patients. It was from a single center. And you never know if there's any statistical quirk in there. So, and when you look at the literature, there's tons of studies that did something similar. They had a morphologic predictor, and then some other group tried the same, and they found the opposite effect of the same predictor. So we were somehow prompted to, if we really want to provide evidence that is potentially clinically usable, we need to do something better than just a single center study. Even if we think that it's a very smart thing to do and our idea was so great, unless you test it in an independent population and show that it works, it's not really very powerful. And this is where the whole study design for the roadmap ultimately comes in.
Fantastic. And within that, you mentioned the clinical parameter connective tissue disease, as well as four of the imaging parameters that are being collected as part of this multi-center registry. To clarify, these are imaging parameters on CT, correct? Not on either MR or other imaging modalities. Is that right?
That's correct, yes.
Okay. And we're utilizing some of those CT parameters as surrogates, as you had mentioned, of some of the physiologic consequences of the true lumen, false lumen hemodynamics. Great. Within many of the institutions that I'm familiar with, measuring aortic diameter by CT or any other modality is pretty straightforward. But some of the other imaging parameters you mentioned are not as necessarily straightforward. For example, what the involvement of the circumference of false lumen is, or the number of intercostals that arise from each of the lumina. Do you think that these more complex imaging parameters might be feasible to implement outside of a research setting or a registry such as this one?
You actually bring a good point because this was one of the learning points of our study. We thought that it was pretty straightforward initially, but then we quickly realized that the interobserver variability, it was not that great. And so we needed to streamline the process a little bit. In fact, in the paper, we outlined how we built a custom workflow that was built on Terrarican in order to reduce any sort of inconsistency in the way that the workflow uh, was completed. And so we always started with the center line, going for the aortic diameter, and then false lumen circumferential angle. And then we had to decide basically the aortic branches ostium, whether it comes off the lumen or the false lumen or the true lumen. And finally, the most tedious one, which was the identifying the intercostals where the aorta was dissected. Um, there is a point in having features that are easy to integrate in the clinical workflow. But to be honest, in my career, even as a resident, I don't remember to having ever agreed on a diameter with another physician. I'm sure that's a common experience. And so it's nice because we were able to publish this earlier in the European Journal of Radiology, this experience with Martin Willeming. And we collected the experience and brought it over into this registry to make it a little bit more streamlined. So I think the final message is it is possible, but definitely there has to be some training and people have to agree on how to measure things in order to keep results reliable.
Two follow up questions to that. Within the registry, will there be a core laboratory that will be adjudicating the imaging findings? And second, do you anticipate that there may be a even more automated approach to performing some of these more complex analyses in the future, even if that's not in place at present?
That's an excellent point. We're going to be the core laboratory like here at Stanford. We collected a fair amount of experience with different scanners, different workflows, different software. Eventually, we decided to go with TerraRecon and build a custom workflow with that.
Yeah, the second question I had with regards to the imaging analysis, while it will certainly be performed by experts at a core laboratory setting, I wonder if eventually allowing it to translate to the clinical setting may be improved by a more automated process, whether that be maybe semi automated or fully automated. And this may be a little more speculative in terms of your response, but I'm curious to know if there is any work in that particular field in automating some of the aortic dissection parameter analyses.
No, absolutely. I mean, if there's something that we learn is that probably this time is better spent doing something else. I mean, these are all pressures measurements, and we believe there's value in them. However, in terms of scalability, it's probably better to look at a solution that is possibly AI-based. So this is also the reason why we want to have a workflow that could be replicated and have some machine learning approach in order to automatize this kind of. It also helps us to understand if the measurements are consistent in terms of like results.
Excellent.
Yeah, maybe I can add to that. So we did in fact try to at least come up with labels that could be used to teach an algorithm to do those things, because obviously identifying the true and the false lumen would be very helpful, and identifying landmarks. And we have done two separate projects, which are, I mean, not clinical grade yet, but we have three projects or three publications where in one of them we developed an algorithm that identifies the true and the false lumen automatically. And we have one that was focused on identifying thrombus within the false lumen, because that makes it even harder to detect a dissection. That's in fact a difficult thing for an algorithm to do. And the third one is currently ongoing. It's an algorithm that tries to identify the branch vessels. It's a landmark detection algorithm. So currently we're only able to identify the landmarks, but not yet to connect them with the true or the false lumen. So those are ongoing things, and as you, I guess, um, implicated that once you do all the labeling with all this work, you might as well use that information to hopefully train an algorithm to do some of those things in the future.
With regards to what to anticipate in the future, the intent of doing this seems to be to help prognosticate which of these patients will potentially do poorly or have a higher preponderance for adverse outcomes in the future. How might that model function? Is this a weighted model for each of the parameters? Is this more binary? A patient that meets X criteria will more likely have an adverse event. And perhaps we can use this to further describe what sort of adverse events we're looking for in the future.
Yeah, I can maybe answer the first part of the question. So the initial model that we used, it gives a score. So, and the score is, I think it can range from like 0.5 to 0.9 or something. And so you can ultimately then use thirds of that score. So you have the lowest third, you would think, well, that's the patients who do well. The intermediate score is the ones who hopefully do well. And the patient who had the highest score would be the ones that would be most likely to need an intervention. So that's what I, in an ideal world, would come out of this. And then you could say, well, if your risk score is very high, then you probably would benefit from an intervention.
So we're looking for revents, essentially any kind of admission that is aortic related. So if there is an episode of an hypertensive crisis or anything urgent that would lead the patient to reaccess the hospital. But we're also looking for elective procedures that are based on the parameters that we have to measure. Like for instance, if there's a growth that is a rapid growth greater than 10 millimeters per year, we define that as a late adverse event. So it's a combination of clinical and imaging parameter, which we believe is ultimately the way to go to actually rectify what is the current paradigm in terms of selecting patient high risk.
Excellent. Okay, I think that gives us a pretty good understanding as to how the study is designed. Was wondering if there are any pitfalls within the design itself that are important to note for our listeners who would be anticipating the results in the future.
Yeah, I mean there are obviously a lot of potential limitations simply by the fact that it's a retrospective um, multi-center design that took a long time to collect the data. And if I step back and say, but how did we do this, right? So we said, okay, we have a model that can predict um, late adverse events, or we think we have a model. Now, the surgeon said, well, it's not good enough just to have it in one model. So then we said, well, send us your cases and we're going to test it for you. It sounds simple, but then it needed obviously a lot of um, collegiality, and our surgeons contacted their best friends and the other aortic centers who they knew had at least a database or had some data available and some imaging data available. And then we out of those candidates, we picked those sites where we also knew the radiologists, right? You know, the world of cardiovascular imaging is not that great, so you all know each other. So ultimately, we identified 8 centers other than the initial 2 sites who were willing to share not only their database and their uncomplicated type B dissections, but those who would also be willing to share their images. And for us, it sounds trivial, but that's not really what is commonly done, not in the cardiovascular imaging world, but in in cardiology or where you have cath lab data there, it's typical to do huge core labs, where everybody sends images. But in our field, it's not that common because it's also a rare disease. So we had to contact all those sites, and they had to provide their clinical data and tease it out of all their databases. And then our imaging colleagues had to agree and help to get all the images, get it from PACS, download them, and send it to us, which is quite an effort. But because aortic diseases or aortic dissections are not that common, and the effect of late adverse events are late, the whole process is really takes over stretches over 10 years. Right? We look at that events that happened over a 5-year time period, and then we also wanted to have a 5-year follow-up. So we have like up to 10-year-old studies. And so the imaging technique alone has changed in the last 10 years, as you know. I mean, some images look dramatically different, and as you can imagine, some of the initial imaging studies are, as often in these cases, outside studies, which could be another generation of scanner older. So for sure that is a disadvantage. Uh, Another disadvantage is obviously that the patient selection is can be variable between institutions, and so we don't have any control of how they really got selected. And then for most of the North American sites, another disadvantage is the follow-up. So many of the aortic centers in the US are aortic centers where the imaging follow-up is not necessarily done at those aortic centers. So those who are followed is a sub segment of everybody. So the also when we looked at the data from our contributing centers, so we have a pretty good follow-up from Bologna, from Italy, but we have less good follow-up from our own side, but because the way how the health systems work and how patients are followed is not ideal. So a lot of challenges, but we thought that again, if if the model is really good, it should show some signal. So, and it's I think in that scheme of thing, we thought that it would be a much more credible evidence if we will be able to pull a study like this off. And I mean, the Mimo suggested, in fact, to summarize our experience in designing that study because we probably have to do this in other situations as well to really make a thoughtful decision. How do we get images from here to there? How do we all collaborate? How do we build these databases that combine full imaging databases? But there are a lot of uh, registries that have imaging information, but not the real images, right? So, in at least in the aortic world. So, we thought that others might be interested just in how to how to pull this part off, but independent of what the findings are ultimately going to show.
Excellent. So before I ask about when to anticipate the results of the study, with regards to the databases that you had just mentioned, full DICOM data sets are what you have obtained from each of the contributing sites. So not just this particular study we're discussing, future studies can potentially utilize those same DICOM data for other scientific endeavors in the field of type B aortic dissections. Is that correct?
Yes, that's correct. Yeah.
Fantastic. Okay, so then let's clarify with regard to when to anticipate the initial results of the study that we've been describing in our conversation. Where are we in terms of data collection and analysis, and when might we anticipate the first components of the results from this registry or the study?
Yeah. So currently, the the results will be out soon, and I would expect that we submit it within this year, maybe within a few weeks or month, I would say. Currently, there is a first manuscript exists that has been circulated among all the co-authors, and it's a lot of people, and we got some feedback already. And obviously, I don't want to give away all the final results of what we found, but I can tell you as much as we did not find exactly what we were expecting, which is exactly why you need to do studies like this. So I hope this is a cliffhanger for everybody else to wait for the outcomes of the study. But as one of my former teachers told me always, if you have a good question and an important question to answer, then whatever the answer is, it's going to be important. If a question is important, the answer is going to be important. So we'll we'll hope to be able to submit this very soon. And from the entire design that we learned and the experience, as you said, we have now a large database. Ultimately, it turned out to be more than 500 patients with uncomplicated type B aortic dissection that were initially built into the database. Then a lot of them had to be excluded for all kinds of reasons related to a retrospective data set. But I think it's a very a powerful tool to do all kinds of things. In this particular study, so the roadmap study was really done to test this initial model that we had. But as you said, once you have the data, you can test all kinds of other models. But you can train an algorithm, you can do other things like this. But again, it's always a humbling experience if you have to do all the work that you recommend others to do by yourself. It turns out that you should do this prospectively. You should do a bigger cohort, and if you really do it, you'll see it's not that it takes a lot of resources and patience, and as I think everybody in the research world knows why it's called research. Right?
Well said. I think it's easy to play, to use a couple of metaphors, Monday morning quarterback or reviewer number two, and suggest a lot of substantial changes to study design that are not very easy to execute in the real world. So, yeah, a great insight into what many of our listeners are certainly eagerly anticipating. Um, a general question from my end is what we see quite often at our own aortic center is patients who don't necessarily have type B, but rather type A aortic dissections who have been treated, particularly with ascending aortic grafts or something to that capacity. I presume that these data may not necessarily apply to that population, seeing as it's a different type of dissection, but I wonder if you hypothesize that the results from this study may apply to this patient population that I see quite frequently, the treated type A's that have a residual dissection flap extending down into the descending aorta and beyond.
Yeah, I mean, that's a very valid question. And there are some papers who just uh, pool those patients, right? So they just throw them together and say, well, a chronic B is the same as a treated A with like a status post ascending or hemi-arch repair, and you have a residual dissection. And they would argue that in the end, we're treating with a patent false lumen that's pressurized, and it doesn't matter if it was a B to begin with or if it's a post-op A. So I'm not sure. I mean, they are a little bit different. It turns out that when you look at all the data, that repaired type A's almost have a better survival than unrepaired B's. But the pathophysiology would should be the same. Right? It's a false lumen. It's pressure that acts on a abnormal thin outer wall. The physiologic parameters, like what flows in and what doesn't flow out, um, applies theoretically to both of them. And there was some 4D flow data from the Barcelona group who looked into that, and they pooled the post-op A's and the B's. So we have not tested our model in post-op A's at all, and so I, I don't want to make any predictions if it was going to work there or not. But in principle, the problems are obviously very related.
Excellent. I think that this conversation has been fantastic and comprehensive so far. I was wondering if you all have any final thoughts before we conclude.
I was just saying that, it's kind of unconventional to have a paper like this as a study design. Usually it's considered something minor, but I really wanted to highlight that this is the summary of years of work, and we hope that the examples and all the errors and all the mistakes have been done to create a workflow that can work for a multi-center study can be of help for other researchers that want to do the same, either if it's in the vascular area or in cardiothoracic. Because I personally learn a lot, and I think this is the way forward.
Yeah, I would second this because the idea to write this up as a study design paper was really Mimo's idea. I didn't really think about it, and we were struggling with all kinds of things, pulling this off, kind of getting the data. I mean, as you know, just the administrative work alone is a nightmare. You need IRBs for each and every site. You need a collaboration contract with each and every site. Everything needs to be updated, and then to get the images even here. Compliant with each institution's different regulations and putting them in one database and all together. It was a lot of work, and then how to streamline the separate clinical and imaging databases is challenging. And then the unique thing about studies like this was that the outcome parameters could be like an event that is a clinical event, but it could also emerge over the follow-up period. So that makes it very difficult to do this. And Mimo said, well, we have to write this up. We have to explain this. And I thought, first of all, I don't know, we just present the results. But then I thought about it, and I would have to agree that, I mean, we all have to go through these steps. And I think more and more of us we'll have to produce higher quality evidence. It takes more work and more effort, but I would have liked to see another paper who had described some of those steps. It would have helped me. So ultimately, we thought, well, maybe it's going to help others as well to design and plan studies like this, or take it as a warning to not touch it.
Absolutely. I think I can speak on the behalf of many of the aortic imagers out there that we are very grateful for the efforts that you and your team have put together to create and analyze this registry. We're all eagerly anticipating the results of this, and I think the cliffhanger you've put together is building the suspense even further. Thank you both for joining me on the podcast. I think this conversation has been super informative and is going to be of real interest to our listeners out there. Thank you to our listeners as well for tuning in. If you like what you hear from us from the Radiology Cardiothoracic Imaging Journal podcast, please rate, review, and subscribe to us. Thank you very much, and we will see you next time.
Thank you. Thank you for having us.